And yeah, thanks very much, Francois. And we really appreciate you stepping in to talk to us about this somewhat depressing topic, but an important one. Thanks, and over to you.
Thanks, Jimmy. Now it's been recorded as probably the real reason I'm going to get deported from the US when I go there in 2 weeks' time. So just, yeah, I was told this is the most depressing lecture somebody ever attended last week. It's about the 10th time I'm giving it in the last month as well. So it obviously has resonated with a whole lot of people. I'll try and go fast, and you're obviously welcome to the slides for what they're worth. Some of the stuff is officially available, some of it slightly less officially, and I'll tell you why in a moment. I'm going to end with a little bit of politicking, stuff Jeremy and I've chatted about, and just I think where we're hitting a bit of a tipping point in the health system in South Africa, and this might be the thing that tips us over the edge. In fact, I've got a whole meetings after this to talk about this. So these are my various disclosures. So the reason we're here is obviously this massive assault on science that we're seeing across the board from the States. I'm going to focus mainly on the PEPFAR stuff, but I think it's quite important to understand that it's way beyond that. A whole lot of people I know have lost their jobs. I just came back from the States, from the CROI conference at the start of March, and I've never been in a situation where people from Harvard and Yale are kind of asking me for jobs, you know, like senior professors in medicine. So the world's changing, and it's never going to go back to the way it was, even if a lot of this funding comes back. And I think we can, it's not necessarily looking forward, but I think the whole of things have shifted dramatically. It's also important to understand that the funding shifts have gone way, way beyond HIV. And I think many of the people on this call know that. I think we've seen it in ways that I think I was quite stunned at how much American funding was going elsewhere. And in certain countries, the entire health system was funded by the Americans. Say, for instance, Zimbabwe and Malawi are two cases in point, but lots of other countries, big chunks of the health system was being propped up. USAID, for instance, was propping up famine and disaster relief, and just people literally starving to death in chunks of the globe. USAID and NIH research, many of you are being touched by this, funded about an estimated 70% of sub-Saharan Africa's research budget, and a huge chunk of South Africa's research budget. There's an announcement that the South African government is stepping in to help fund the South African, the MRC, as of this afternoon. So hopefully there's some good news there, but it's still, it hurts sort of research desperately. But it's everywhere. It's governance, it's climate, it's vaccines. I mean, I went onto the CDC website all the time to go and get updates on vaccines and things. And now, you know, it's so contaminated with ideological statements and things. It's not a safe place to go and get information from. The FDA is being gutted. You can't travel around the United States because of the air travel safety is compromised. There are all sorts of problems. And I'm going to talk just about some of the infrastructure projects that have been touched. So it's not just HIV, or it's not even just infectious diseases. It's everything that's been hammered by the American sort of defunding of science, and by the nutcases that they seem to have employed there. And some of the responses have come back, and as always with these kind of things, there are grains of truth in some of them within our own country, which is, it's time we stood on our own 2 feet. The Americans should not be blackmailing us like this. Now, that is partly true, and I certainly think it's absolutely shocking that the South African government and Department of Health has been so reliant on PEPFAR, and I think it suited both parties to be there. It is very easy, though, when you're on a very plush medical aid paid for by the taxpayer, to be able to say these things. So when you're a person who's completely dependent on the state system, it's not that easy. It's, you know, to say those things. There's this constant thing I hear, which is that HIV gets too much money anyway. It's time that this was righted, with no evidence to support that. You know, HIV still, even though we've got it under control somewhat, is not a minor problem in our country in terms of burden of disease. So this idea that HIV somehow gets too much money is deeply rooted in sort of public health, but there's no evidence to suggest that it gets too much money or too little money or gets the right amount of money. There's this idea that the Treasury and private sector must urgently step in and fund the PEPFAR program. We all know that countries have a budget crisis, so this is difficult to see being justified. This statement, which comes through again and again, particularly from public health people, and I hear it from government all the time, which is honestly one of the most empty statements about this. I've heard it for like 30 years. We must strengthen health systems and integrate HIV into the rest of the system, which is essentially make it as bad as everything else. And I'll come back to this in just a moment, and why some introspection around that statement is important. And then finally, the faith-based approach, which is we're going to be fine, we're South African, we can be resilient. And I think for all of us on this call involved in the state services, comes a time when we actually get a bit tired of being South African and being resilient. Like we're constantly sort of told to step up. And there does come a moment where enough with the resilience and more with government doing its job. And I think this is where I think there is a bit of a tipping point that's been reached at the moment. I'm not going to talk about politics until the end of this lecture, but it is interesting to see that we seem to have exported some of the most awful South Africans across into America with all the expert state capture techniques learned from the Guptas, and they have taken over in America. And it is remarkable. It's not just Elon Musk, but there's about 5 or 6 of them who've taken over the whole of the American government. And some of them are proudly Wits graduates, like Patrick Shinshon, who is a notable vaccine with still some ties to this university, and certainly to Stellenbosch University, having given them huge amounts of money, who's a real vaccine denialist. But for those of you interested, Chris McGreal, who was my next door neighbor during the Mandela transition, has written articles about these guys who all took over PayPal, made their billions there, and then went and took over the American government in the last few years. So it's a fascinating bit of history. And now we're about to send 65,000 other people to the millie fields of Idaho, by the sounds of it, to go and go over across there. It's interesting to notice that none of the leadership of the people who've negotiated this are going across. So those of you who are interested in the South African history of this can go and read this book that's come out about the PayPal founders, which includes Elon Musk. Anyway, let's talk about HIV and how we got there. I'm going to give you a very, very narrow history of it, but a very famous endocrinologist from Wits came to me in 2023 and told me this, and he's right. He said to me, treating diabetes is hard and treating HIV is easy. And honestly, this is correct. So I was looking at this little sort of pill counting thing up on the left there about how we used to hand out to our patients in 2004. I managed to find amongst some documents when I was cleaning out my house a few months ago. HIV in 2025 is easy. I think we all know that. You kind of give them a single tablet and you say, go away and get better. We diagnose them on the same day, we give them the tablet on the same day, and they go away. And in most cases, it really is a doddle. But we must remind ourselves where we came from. And in 2003, it wasn't that easy. We gave them several tablets in the morning. We gave them several tablets at night. We had to dose adjust them by weight. We had to wait for the blood results for the test to make sure they were HIV positive. There were no rapid tests in those days. The CD4 count took ages to come back. We had to vary it according to what their CD4 count was. We had to give them all sorts of opportunistic infections. We gave them different regimens if they were women of childbearing potential. And there was, I think I'd forgotten until somebody from Harvard reminded me, was this whole issue of covering the tail if you stop the drugs for whatever reason. We stopped the drugs quite often for toxicity. So it was a bit of a drama. In fact, it was much harder to treat HIV in 2003 than it was to treat diabetes. So it's important to remind ourselves how far we've come to get to this one tablet a day. So it wasn't as simple as the diabetes people like to make out. It certainly was, it was difficult. And a lot of getting it to the simplicity was PEPFAR. And a lot of PEPFAR was about making things as simple as possible. Up on the right-hand side was the first head of PEPFAR, Ambassador Tobias, opening one of the clinics at the beachfront in Durban. This was actually taken at Addington Hospital. I was down there for the opening. He was retired when he was found in bed with a whole of hookers in Washington, D.C. a few months after this photograph was taken. A great way to go, I think. And then was promptly replaced by Mark Dybel, a pediatrician with an ARV resistance interest. But this first announced of all people by, I think people often forget, by the Republicans in 2003, and was very actively supported by both the Republicans and the Democrats, which is why this current bizarreness around Trump is pretty bizarre. It's been implemented over 50 countries, and they've invested billions and billions of dollars. It's easily the most biggest commitment in terms of funding to any single disease. And it's been laser-like focus on HIV. There's nothing, they don't mess around. They do a bit of TB on the side because they have to keep the patients alive. And they do prevention, they do treatment, but they keep it on HIV. And there's been a lot of criticism. People say, why don't you do hypertension? Why don't you do contraception? Why don't you do vaccines? Why don't you do clean water? But they've been very good at keeping it to HIV. And I ran a massive, in fact, the biggest PEPFAR program for a while in the world in the mid-2000s, and then continued to run until about 2012. It pays for different things in different countries. Like in Malawi, it pays for everything. In South Africa, it plugs some gaps. In Kenya, it pays for about half the program. And honestly, my assessment of PEPFAR, and I'm very critical of aspects of PEPFAR, is it brings the best and the worst of the Americans. I remember seeing one of the heavyweights from PEPFAR when I was whining about how terrible my life was when I was running the program in the mid-2000s, and saying how difficult it was. And he turned to me and he said, I pay you for solutions, not for problems. And it really gets to the heart of it. They would go to us and they would say, this is what we want you to do. We've got money for this. If you don't want to do it, we'll give it to somebody else and we'll do that next week. And it's a horrible place to work, but they're incredibly focused on you delivering on where you are. And you got very good at doing it, honestly. And there's something here to be learned by healthcare systems is you focus on one thing and one thing only, and you pay people to do it, and you get them to do it well. And this is the propaganda. I'm not going to bore you with the stats, but even if half these numbers are true, it was a remarkably effective and cost-effective program. They paid for results and they got them. And by whatever metric public health uses, this thing delivered. They delivered well in terms of quality of life, number of lives saved, number of infections averted, did very well. And where it did well, and it was important in South Africa, is they went where the infections were. They didn't go and mess around in the farmlands of South Africa where, infection rates were actually quite low. They went into the urban areas, they went into the squatter camps, they went into where transmission was happening, and they hunted down where people were and they linked them to care. So just to quickly talk about South Africa, we started out looking very similar to North America and things. We had our first cases in the 80s, and because our borders were pretty much sealed because of apartheid, we looked very similar to, as I said, North America and Europe during those first few years. And until then, it was pretty much, it wasn't really much of a problem, except for in these very, very key population groups until the 90s, in which case it exploded across the country. And then during that time, during the 80s, it was pretty much palliative care. There were no ARVs. You pretty much pickled people in Bactrim, and if they were lucky, they got a little bit of AZT, which prolonged things by a few months towards the late 80s. But really in the 90s, that was when the ARVs came along, and they were very, very toxic in those days, but the hospices almost pretty much closed overnight. But that was also when the explosion in mortality started to happen across Africa, and when South Africa started to see the big numbers happening. When I came along and started getting involved in HIV was when the ARV started to become a big advocacy area, and when the kind of Mbeki Mantu denialism area was happening. And in 2004, which is when I think many of you might have started to watch things starting to unfold, we started to see public sector access. And then Zuma came along in 2008 and swept everything aside. Motsoaledi came in, and we saw massive scale up of the ARV program. And a lot of the last 15 years have been really about making the treatment more accessible. We got same-day treatment, we got rid of D4T, we got rid of efavirenz, and things just got better and better. So ARVs just got simpler and nicer. And a lot of that was part of the PEPFAR program. They made it just faster and faster. So as of last week, we got these updated numbers. We got about 8 million people with HIV out of the 60 million of the population. There's about 6 million people on ARVs, a handful of people on second and third line. And life expectancy shot up. It used to be number one, the number one killer. It's sitting at about number 6. And TB and diabetes are sitting at number 1 and 2. Obviously, there's a bit of a Venn diagram there with TB. And our infection rate, our new infection rate in terms of the new Tabisa model last week, says it's come down from 500,000 new infections down to about 170,000. And there's been a dramatic drop in the pediatric numbers. And you can see across the Southern African region, PEPFAR, which is focused on all these countries, has had this incredible impact on HIV mortality, which I think we've all lived through now. It's still there, and it's still a big problem, but it's really been remarkable what's happened. South African life expectancy has gone up. back to where it was when HIV started to take hold. It's really interesting to see how COVID really hammered us during that 2-year dreadful period we all are not sorry to see the back of. But you can see how Tembisa's model that if we continue with the ARV program, how our life expectancy is going to steadily creep up towards that magical 10. And it's across the world that mortality is coming down, new infections are going down. It does obscure the fact that there is incredible differences in how transmission happens. So in some parts of the world, it's really focused amongst gay men, amongst certain parts of the world, it's really amongst drug users, and then certain parts of the world, like our area, it's still very much focused on heterosexuals, although there are very high pockets of infection amongst certain key populations as well. And as you can tell, it's still a very big problem. It's not an African problem. You can see up in Middle East and North Africa, it's still a relatively unusual infection. But down south, you can see it's still where the action is happening in terms of the infection. It's still, there are big hotspots in Eastern Europe and Central Asia, and that's certainly where the new infection rates are still going, in Southern and still in Asia and Pacific, still a remarkable number of infections, but still Southern Africa is where the big numbers are. So how bad was it? So when I was training, it was just an absolute, I mean, it was a storm. At the gen, you just couldn't walk in the medical wards. There were just bodies everywhere. People just died. There were 10, 20 death certificates written every day in the intake ward. And I didn't do my training at Barrow, but I can only imagine from what I listened to, like it was exactly the same. And Helen Joseph was exactly the same. Wherever we worked, it was just shocking. And these are all much younger photographs of all these people, many of whom who were involved in fighting around HIV and trying to get access against the then denialist government. And then all these activists were involved. And it's really interesting because since PEPFAR fell apart and these people are involved in the groups of new people taking on governments, taking on Trump, taking on everybody in a group called Change. They've all stepped up again, obviously 20 years older, people like me who've got less hair, to take them on again. The same faces. I mean, one of the things that worries me is the fact that it's the same people. We haven't got a new generation of activists, or very few people new who are new coming in. But what is interesting is it is a lot of the same people stepping up and starting to fight back again, internationally and locally. So what did South Africa have? Well, when we had initially started with HIV, we had this massive inpatient wave, people with very low CD4 counts. When I was running the program, one of my things that was so frustrating was the average CD4 count was 80, and I couldn't get it above that. I didn't know how many resources I deployed, how much money they gave us. We just couldn't seem to get on top of it. These people just, like, a quarter of them came in with TB. There were still so many patients with crypto, with pneumococcus, all those ghastly issues. And it just went on and on for years. And finally, we started to send people into the community. We started getting people tested much earlier. We started testing in the antenatal sites, out in the clinics, and we started to get on top of it. And we got the CD4 count up from 80 to over 400, which is where it's sitting at the moment. And the village idiot can treat somebody with a CD4 count over 400. At 80, you need an academic hospital with all the toys, because you really are going to see iris and all the ghastly stuff that goes with it. You really need a lot of help. And the antenatal transmission rates dropped right down. So actually, pediatric HIV is actually relatively rare in South Africa. And it was similar in the rest of other African countries. The only difference there is in South Africa, we have, our hospital and our primary healthcare clinics are very functional. So they didn't have to pay for that. While in places like Malawi and Zimbabwe, they actually had to pay for everything, including the laboratory. We had the NHLS, which is pretty functional. So PEPFAR didn't have to pay for that stuff. They had to pay for the case finding and the key population programs. A lot of the work I was involved in was just trying to do a lot of the kind of sort of different guidelines and things we had to keep adapting around that stuff. So then Zuma came along, swept aside all the denialism and nonsense. One of the few good things I think he managed to do. And as of the PEPFAR disaster, we had these 6 million people on world-class therapy. And honestly, I think we all know how amazing that this first-line therapy, the fact that we have so little toxicity on TLD is testament to all of that. And one of the interesting things, when you look at the kind of things that kill South Africans now, increasingly it's non-communicable disease, how infectious diseases again is slowly, being replaced by this onslaught of this really interesting intersection between infectious diseases and non-communicable diseases. And even though we all think we're all going to be murdered in our sleep, and homicide and things like that are such a big deal, that's actually a relatively uncommon cause of death in South Africa. Still, obviously not a nice thing to have, but this non-communicable disease wave is the one thing that we were grappling with. And certainly you were all bored listening to me carrying on and on about obesity and all the stuff that we're having to grapple with. And a lot of the work that I was focusing on, which was around GLP-1s, and I'm having to pivot very rapidly back to advanced HIV. The only reason I'm showing this slide is so that I can brag about my command of AI, and having spent probably a good month trying to work on this slide to make this ring work, and I crippled probably, I don't know how many servers doing so, but just how good TLD has been for the South African program across the area is that it's completely replaced efavirenz, and it's really made, because of its better side effects, its better persistence, its better resistance profile, and the fact it's cheaper, has made the HIV program, certainly in adults, just so much more robust, and has, given us so much, just made things so much better. And I think, again, lots of lessons here for diabetes, for hypertension, and a whole range of other things. And it's been a massive public health success, even in places which don't have viral resistance testing. But then this came to a crashing halt in January. So we were doing so well. I was chairing a CROI discussion at the big San Francisco talk that was being held. These are all people involved in Malawi, Kenya, Zimbabwe, Zambia, Uganda, frontline people, and they were talking about the experiences. And it's quite clear that it varies quite remarkably from country to country what happened with the PEPFAR being removed. But what was the one thing that was common is it was completely devastating. The one thing everybody talked about was just, it happened literally overnight. I know in Joburg, for instance, on Monday, the stop orders were issued. On Tuesday, every single clinic was shuttered. All the testing stopped in central Joburg. All the HIV testing, the outreach services stopped. Every single key population, so all the stuff to drug users, sex workers, LGBTI populations, those all were completely stopped. For South Africa and Botswana, there was a lot of problems with supply lines. I was quite shocked. In Botswana, almost all the program was actually funded by PEPFAR, and they just didn't know where their drugs were. In South Africa, there was I'll talk about it in a little bit more detail. There was a lot of technical support to the Department of Health. In Kenya, the electronic medical record was completely, which was linked to the lab system, was completely funded by PEPFAR. All the tech people went straight back to the USA, and they sort of shut the system down. So you'd be a patient who would say, I'm part of this clinic. You'd turn up at the clinic, and they would have absolutely no access to your record. So we'd have no idea of what had gone before. So luckily you're on TLD, so they would be able to give you a TLD, but they would have no idea of what your CD4 count was, whether you had TB or anything whatsoever. So that was an absolute disaster. Uganda, it was very similar, although it was in some ways even worse because it was linked to their stock-taking system. So Uganda knew they had drugs, they just had no idea where it was, whether it was at the pharmacy depot, whether it was at the clinic, whether it was en route from the pharmaceutical company. In Malawi and Uganda and Zimbabwe, the entire health service force went home. So there's no one to actually see the patients, hand out the pharmaceuticals, do anything. And that's to a smaller or greater extent still the case at the moment. I'll talk about the Zimbabwe health test at the moment. And one of the interesting things at this symposium, which was held, somebody turned around and said, well, if the money does come back, it's probably not going to be very much. What could you cut? And the only person who had the guts to stand up and say what he thought was actually the Zimbabwe guy, who I kind of feel should be our health minister, because he was like, I would cut this, this, and this, and was just completely like, this was always nonsense. This was always a waste of our time. This should have been the stuff that should have gone in the first place. Everybody else was just pussyfooting about the whole thing. There have been several reports. China came out and demonstrated just how much this disruption has been across the board. And as you'd expect, the children are always the canaries in the mine. And that's been felt first, is the pediatric formulations have fallen apart. For prevention, those prevention programs have almost completely stopped. And that's certainly what's happened in central Johannesburg. Like almost every single prevention program has just stopped almost completely. This WHO report, these slides are freely available online. It's quite a long report. They do surveys of all the countries affected. But I think the only slide I wanted to show you from this report, which is really interesting, was they looked at this level of service disruption to the HIV program and said within the first few weeks, it was the same impact as, it was 3/4 of the impact of the COVID disruption at its worst. So within almost no time across the board, on average, it hit 75% of the COVID disruption across all these areas. So you can see how quickly the PEPFAR disruption had affected services. And it's not just HIV. In TB, which is being supported by, at the same time, huge amounts of case finding has been hit. Now, you all know that TB is another success story in South Africa, that we've been making inroads in the last 20 years steadily in new case detection, in terms of cure rates and everything else. And this paper, which also came out last week, demonstrated just how much these programs, this came from Aurum, one of the big NGOs that's based here in Johannesburg, but has a footprint across the country. Just the sheer number of case finding and linkage to care and that they were doing, that's fallen by the wayside. Now, one of the comments when I did this this workshop I was facilitating in San Francisco, the Zimbabwean guy stood up and he said, the African governments, all the ministries of health said, don't worry, we've got this. This is difficult, but we've got this. And he said, what were we going to say? We had to. We're the government. We can't say things are out of control. We're responsible for this. And even though we know we haven't got this, we had to put out these statements that we've got this. Like in Zimbabwe, no one's there. We can't pay for this. It's absolutely out of control. It was a very frank and terrifying statement to make, but he told the truth and he said, we haven't got this. The South African government, sadly, thinks it's got this when it patently hasn't got this. And the problem with the funding is that the amount of money that's gone into the PEPFAR program is so huge. There's no foundation. No Gates Foundation has got the money. The Novo Nordisk Foundation, which is absolutely massive, hasn't got that much money. The only people who plausibly got that much money are possibly the EU, and they're all fighting this Ukrainian war, and they've been withdrawing funding for the last 10 years steadily. So I don't think they're going to be coming over the horizon to come and save us. So the low-income countries don't have the money to replace this. And places like South Africa, and Zambia, which are firmly middle income, have their own sort of funding crises at the moment to have to deal with. So this is a particularly a big disaster for all these countries. And even though South Africa, Botswana, and Namibia largely funded programs, although I hear now that Botswana actually wasn't, they were funding most of their program. The bits that they were funding actually were significant enough to still hurt them. The rest of the country were talking about integration. And it's one thing for South Africa to talk about integration where our primary healthcare services are functional. In in Zimbabwe and Malawi, for instance, there is no primary healthcare service to speak of. There are a couple of places where there's sort of a clinic, but when your massive HIV program, you're suddenly sending thousands and thousands of HIV patients into a primary healthcare service where there's barely a functional nurse. It's not the same as in South Africa, where there's a pretty busy clinical service which can absorb it. And this is what's happening at the moment, is that all these people are being transferred into a barely functional healthcare service. So it's an absolute disaster in these other countries. It's a very different situation in South Africa. And if you go out to the right here, I'm not sure that you can see these slides. My Zoom is obscuring it. I'm just going to move my thing over across there. But you can see how dependent some of these countries are on foreign funding. The very dark blue talks to how much of your HIV program is dependent on foreign funding. And you can see South Africa is largely independent. That talks about 87% of its funding comes from from the tax base. And you can see Kenya is over 50%. And if you go out to the left, you can see places like Malaysia and Colombia are completely independent. But you can see a place like Zimbabwe, Mozambique, Malawi are completely dependent on foreign funding. And most of that light blue, which is not directly American funding, is global funding, which also comes from the Americans indirectly. So Zimbabwe, Malawi, Cote d'Ivoire, these other countries are in a parlous state with these funding cuts. So what the whole of modelers got stuck in, Brooke Nichols and others who are based at Wits through Hero got stuck in and immediately showed that once PEPFAR goes away, as you'd expect, new infections come along, deaths start happening, and all the bad stuff is on its way. And this PEPFAR count has got lots of international, this kind of updates every 5 minutes or so. It tells you how many deaths and how many new infections and infant deaths and things are going to happen. As I said, all the modelers and have got very busy churning out papers over the last 3 months. This paper, which came out at the end of March in the Lancet, just tells you exactly what you'd expect. Just lots of death, lots of new infections. All the stuff that we were getting on top of is coming to pass, is going to come to pass. Now, lots of very brave people have got stuck into have got stuck into lawsuits against the United States government, at the level of universities, NGOs, human rights organizations. And a lot of people have come back here and said, well, including people in the South African government and South Africans have said, you must just go and provide the services. And one or two lawyers from America in DC have said, don't worry, go provide these services. What they're doing is illegal. It's absolutely fine. Now, I don't know how much you guys have been following American politics, but everyone keeps telling me that what Trump's doing is illegal, but no one seems to be able to stop him. Now, when you're a dippy little NGO taking money from USAID or from PEPFAR, and having run this program by myself for many years, like when they say to you, we will not pay you if you go against what we've told you, and they issue these stop orders and say, you will not provide services as of tomorrow, you stop your orders. And when they say, you will stop until you're told to start, you wait for a wet signature that is issued you from the United States official that is based in Pretoria. You don't listen to a lawyer sitting in Washington. So none of these NGOs are going to step up and take the financial risk, which will cripple them, to go and restart these services, unless they see that money is coming back to them immediately. So when so people say it's absolutely fine, what he's doing is illegal, and there's some federal judge that's issued an order that these things must be restarted. That's not going to make things better for the services to get restarted, in Kampala or in Mozambique or in Johannesburg. Nobody's going to get out of bed and come back to work with that sort of thing to be allowed. So what did PEPFAR actually fund in South Africa? It's 17% of the budget. And interestingly enough, it was not the consumables. It was not the lab services. It was pretty much 90% of our drugs. Global Fund, for some bizarre reason, paid for some of our drugs. I still don't quite understand why, but they did pay for a lot of the smarts. They paid for over 200 technical advisors to the Department of Health, to the National Department and the provincial departments. They paid for the key population program. So when they have a sex worker program, which I ran for many years in Hillbrow and across the country, they'd pay for the nurses and the mobile vans to go out there. The Department of Health would pay for the STD drugs, the condoms, the ARVs, the labs, but we would pay for the nurses and the actual service delivery. The NGOs would be paid to send the counselors into the community, to sit in the clinics, to go into the antenatal sites and do the counseling and hunt down the people with HIV, and then shepherd them across to the ARV clinic and say to the nurse, which was paid for by the DOH, this person has HIV, please start the ARVs. And if they fell off the program, they would chase them down and say, listen, I understand that you haven't taken your ARVs. Can we help you get back into the system? So there's a lot of the nice stuff happening in the background. And it's interesting for me to think about if we did that with diabetes, or if we did that with hypertension, or we approached that differently for TB on scale, like how much more we would be able to do in those diseases if we hadn't, if we had the same sort of drive onto those diseases. They also didn't mess around with the districts where HIV wasn't that much of a problem. They focused on the 27 districts where they had worked out just under 80% of the patients with HIV lived. And they would move from place to place. Once they went to a hotspot and they worked out that they'd saturated that area, they'd move on to the next place and they'd focus on that. And that's why we have a situation where the average CD4 count is greater than 400. And again, I come back to diabetes. If we did this with diabetes, we wouldn't be finding people when they come in with renal failure or with foot feet or going blind. We would find them when the HbA1c was 10 and they were like slightly symptomatic, and this is just a real public health lesson for how to do things properly. With it, we also lost all the TB screening support that was allied to all of this. The other thing is we lost a lot of the data systems. We've got some data systems which are still functional. I'll show you some of them in a moment. And we've also lost a lot of the key technical support. And there were some really good people working at the Department of Health holding things together, which are slowly being dismantled at the moment. And with it, all the key population programs, which just, as I said, just shut it overnight. And obviously, these were very high-risk people for HIV. Those people all out getting HIV, transmitting HIV, getting TB. And the other thing that was happening, which many of you probably don't know about, is they were funding TAC and a community quality program to go from clinic to clinic in each one of the provinces, monitoring the quality of the services, saying how friendly the nurses are, how unfriendly the doctors are, monitoring whether PrEP was available and those things. So I got this WhatsApp just before this lecture. So this is hot off the press data, just showing you how much some of these. So this is from the clinic data. This is NHLS data. I'm probably not supposed to be showing you this, so look at it carefully. It shows you the difference in the program from 1 year ago to now. Now, you might say this doesn't look that terrible, but this is the established patients on treatment. And this shows you how bad things have got from 1 year onto the next. This is not new patients. This is not the nice add-ons that PEPFAR is doing, finding people in the community, bringing them into care. You can see how things have fallen apart, even in the established patients on ARVs, and how angry this person is with the system. So the minister has this information in front of him and is doing nothing with it. Now, this is one of the few programs that are functional in the Department of Health at the moment. And this is what I get so angry about. Why are they not doing anything about it? Is these are existing patients who are just coming into the system, who should be at the very least fine. I'm actually quite shocked that this is so bad. This is the one area I thought we'd actually have a couple of months actually of grace before the end of the year, before we start to see this level. But if we can't hunt down children with HIV and stuff like that, or newborns with HIV, this is an absolute disaster. In the other countries, things are not great. You can see that already in places like Zimbabwe, we're running into drug crises. There is some signs that they've continued the funding in some of the countries, that there's some crisis funding, but there is evidence that they're probably going to be scaling their funding back even in those countries as a kind of transition zone. But there is no key population program. There's no PrEP. There's no prevention outside of the old ABCs that they had in the past. I just pause for a moment and just talk about our neighbors, because you guys work in Johannesburg, and I think this is the thing that freaks me out a little bit. The program has pretty much collapsed in Lesotho, and it's not just the ARV program. The economies are going to collapse in Lesotho. These huge development programs have collapsed in both Lesotho and Zimbabwe. A whole of that stuff I was talking about, the infrastructure programs and things. In Zimbabwe, the ARV program, all the stuff I'm getting is that, the ARV programs have collapsed. I don't think Zimbabweans are going to come across the border en masse, come and get ARVs. And if they are, they're going to stop at the border, buy them and go straight home. But part of the thing that freaked me out is that there's this 3% of salaries, formal salaries in Zimbabwe, are taxed and put towards an ARV tax. And the guy who heads the Zimbabwe program in San Francisco told me that has fallen by 30% since February. Now that suggests that 30% of all Zimbabwean formal salaries are funded by the American government. And that means that Zimbabwe is about to go into another economic crisis. And they're not going to go, believe me, they're not going to go to Botswana or to Zambia. They're going to come here. And that's, is another problem for central Johannesburg, and another problem for all the health services and all the problems we know about. So again, this is not good news for our health service. And again, doesn't seem to be bothering our government whatsoever. Zambia, my friends, Cassidy is somebody I worked with at the NIH, who's been running programs there, just says it's an absolute catastrophe there. Zambia is a high middle income country now. You may not know it, in terms of the amount it's getting. This I got yesterday from a person working in Kampala about how desperate things are there. So again, absolutely heart-rending stuff. This article, which Lucy Clouvet, who works out in the Eastern Cape, was talking about this term AIDS orphan, which I don't think I'd heard in 10 years, some ghastly term, just talking about the sustainability and the knock-on impact, in terms of children, this series that came out. And our own government just does not seem to have a plan. It's been 3 months and put out a memorandum, which was a faith-based memorandum that came out. Me just ranting and raving here in this article on the left. Put out this letter on the right was civil society asking them, like, where the hell are you? Like, what's going on? And doesn't seem to have a plan as yet to do anything about this. And this is the reason we need to be scared, is that if we don't do all of these things that PEPFAR was doing, we're going to go back to a CD4 count of 80. And you guys who are working in the hospitals know that we don't have a lot of hospital bed capacity. And that means that the little limited capacity that we do have, and we already still have a lot of AIDS patients coming in, is going to be overrun with people coming in with symptomatic disease again. And we go back to that ghastly 2004 to 2008 era when we're able to give ARVs, but we give them when people are very, very ill. We're also going to see a rise in transmission. I'll come back to that in a moment. And the problem is the minister's not going to know, except for these numbers I'm showing you at the moment. They're like being leaked from the NHLS, which don't seem to be causing any sort of sense of urgency. The other issue is the impact on the economy at the moment. And Ian Zander said to me that this is the impact of losing the steel industry, this massive loss of money that's come in, the loss of 24,000 jobs, 20 billion rand a year just from PEPFAR, notwithstanding the loss of NIH and everything else. And then obviously the impact on our neighbors coming in on their economies. And I think the thing that makes me really ill is the fact that we were so close. This new drug, lenacapavir, that I've talked about in the past, giving it 6 monthly, which gives almost 100%, in fact, does give pretty much 100% protection. At San Francisco, we saw that you can give it intramuscularly once a year, possibly even every 2 years. And this was me and Glenda, again, ranting and raving at Gilead. It seems actually just ridiculous because we probably should be ranting and raving just at government, which is that we were in a position to actually end the epidemic, break the back of the epidemic. So we sort of have to pick ourselves off the floor, though. There's stuff that we can do. And one of the things we were talking about is, can we preserve the HIV response? And I'm trying to, a few more slides left. Can we do things differently? And one of the things that did occur to me about the PEPFAR response is some of the stuff is being done exactly the same way for the last 15 years. And can we do things in a more creative way? Can we cut costs? And I know that Elon Musk has made efficiency a dirty word. And I, for one, having worked in the NIH, indirectly with the NIH for the last few years, know that the NIH certainly can be more efficient. I do think there are things within the PEPFAR program that could be done differently, and we can think about things differently, how to deliver services, because we've been doing things the same way for quite a long time. And I think there are things that we could be thinking about differently. One of the things that was made in this point in this Lancet article that came out about a month ago was that when donors do invest in African health systems, you do see African governments actually stepping in and contributing. And this just showed where PEPFAR had been invested, that actually there was quite a lot of domestic investment. This did not hold for every country, but it did hold for a significant number of them. So there's something to be said for some of the lessons learned there. So one of the first things that I've been involved in is to see, can we use less drugs? So we give 1 tablet of TLD to people every day, is maybe we could use it less often. And so when I was in San Francisco, this study came out looking at Biktarvy, which is the drug that they use in rich countries, which is their version of TLD. And for those of you not HIV-ologists, don't worry about it too much. There's absolutely nothing to choose between this and TLD for any rhyme or reason. But this group of nutcase Spaniards went off and started to actually dose Biktarvy, which is also dosed once a day, at once a week, twice a week, 3 times a week, and 4 times a week, to see if they could, once people who established an aviremic, showing can they get away with much lower doses. I don't want to be on the ethics committee and whoever put this forward, but they actually demonstrated remarkably high levels of viral suppression using these different strategies, even in the majority of patients dosed once a week. So we sat with Esteban, who is the last author on the study and who's been helping us try and design similar studies, which we're flogging to every donor we can talk to see if we can urgently design similar studies on using TLD. So if you can use TLD 3 times a week or 4 times a week, we can at least cut the cost even further for other African countries to maybe use their stockpiles of drugs and make it cheaper. So Andy Hill, being Andy Hill, sat at the conference and churned out this meta-analysis and actually showed a remarkable number of ARV studies where this strategy is actually being pursued, mainly in rich countries, interestingly enough. It's so expensive in rich countries that they've been trying these different intermittent strategies for quite a while on different drugs. So we're busy designing these studies and, as I said, talking to different funders to see if we can urgently do an alternative day TLD strategy. There's a study that's coming out in the next 3 months on 5 days a week using TLD, and we're busy with a design looking at 3.5 at half a tablet a day versus 4 times a week. Hopefully we'll get funded and get out the door if we can find the right funder. There's some new co-formulations using islatravir, a new drug, and lenacapavir. And these drugs are dosed at such low doses and they're so cheap to make that we perhaps can get away with weekly dosing and again get the cost of drugs down. It's like a get us out of this hole, but it might further make the program that much cheaper. But this is probably going to take another 3 or 4 years. We've got to get past the patents, we've got to get the whole of safety data. So this is, again, not going to get us out of the hole quickly enough. There are ways, and Brooke Nichols, which is one of the modelers who was involved in one of the studies I showed you earlier, she was involved in different strategies around testing. So rather than sending people into the clinics with HIV tests and doing conventional testing, they would just go in and hand out self-tests. And what they saw is when they did that, a sudden increase in new ARV initiations. And they actually showed it was actually a lot cheaper than conventional testing. So you could get away with different ways of doing testing than conventionally. And I just think that we've been doing testing in the same way for so long that we think this is the only way that you actually have to do testing. I also think that delivering services to key populations, we've been doing it the same way forever, and that maybe that we must just think about doing things differently, particularly in African countries where people like being gay and drug-using populations. It's that African governments have often made it very, very difficult to deliver those services, and we've got so many online platforms and things that we can do that differently. And certainly in South Africa, I think there are just different ways we could be doing this. So just thinking about doing things more creatively. I think the other thing we need to acknowledge is, you've heard me rant about this as well, is that pre-exposure prophylaxis is an absolute disaster. And this slide made me really put my heart in my throat when Chris Vira at the CROI conference actually put this up and showed how dependent PrEP programs are in throughout the world, and why it's not surprising that PrEP has completely collapsed once PEPFAR withdrew. And the Trump administration hates prevention as a whole, it's just, and all the populations linked to it. So PrEP in South Africa has completely collapsed, but it's not just collapsed here, it's just collapsed everywhere. So when we talk about lenacapavir access programs and things, it's just not going to happen because the kind of support infrastructure that was there has been dismantled again overnight to actually put this forward. So we are going to have to think about doing things differently when it comes to PrEP if we are going to get to this. And this is certainly the work that we're doing in private pharmacies in South Africa, I think shows some hope. So this was commissioned by the Department of Health. This drives me mad. It's like they know that we're in a huge amount of trouble, that if nothing happens, and if they don't fund the gap, and if they don't do things better, they are going to see a massive number of new HIV infections. So anything, depending on your confidence interval, between 150,000 and 300,000 new infections next 3 years, and 50 and 65,000 new deaths in the next little while. And the problem I have is that the Department of Health keeps saying, give it to us for our grand NHI experiment, but don't know how to provide the services. They're not good at case finding. They're not good at providing things to key populations. Simply giving them 2.5 billion rand, which is 2.8 billion rand, which is what Nicholas Crisp says is what we need, is not going to be good enough. They need the expertise to provide these services. And again, we're going cap in hand to these other funders to ask for money when actually what we need is people to actually provide the services along with the money. So I've been raging and raging and raging against the Department of Health, saying, we're just not hearing from you. Like, don't you think this is a disaster? And the problem is we're not getting Department of Health engagements on anything. We're not getting on PEPFAR. When the universities have tried to engage with Department of Health on research, they didn't even come to the meetings. Cyril took a month to actually come to the meeting eventually, and he's the presidential. But when the universities went to actually meet with the presidency, the only department that didn't pitch up was the Department of Health. So it just gives you an idea of where the priority setting is. And I met with SAMA on on Friday, and as well as with civil society. And they just said they cannot get any engagement on anything, not just on this HIV crisis, but on NHI or anything else. There just doesn't seem to be anyone at home to be able to do anything. And I thought that I sent this to Jeremy, we were chatting about, is that I don't necessarily enjoy the politics of this particular presentation. This is Adrian Gore from Discovery, was just talking about South Africa and just how good people from our class have it. People who have medical aids, who have insurance, who earn a reasonable salary. Just actually, why on earth we would ever want to emigrate to America? Like, you'd have to be insane when those of you go to the United States or go to the UK or places like this, just how fantastic we actually are. He was pointed out that the GDP of Gauteng is the same as Ukraine's GDP, and it's half of the New Zealand GDP. Is that how sophisticated our banking system is, how many pension funds we have, just how good we have it. He had crime statistics showing how dramatically the crime claims at Discovery have dropped in the last 10 years for things like car hijackings and death from crime, and like all hijacking, petty crime and all the rest of it. And he also pointed out how quickly they'd fixed Eskom, like how quickly they put together an expert group and had taken care of it. Now, I'm just going to finish with my last slide, which is, why can't we have an expert group fix the health system? And I was chatting to Simon Self System and saying, we just left it to the minister he's been the minister for most of the last 17 years. And our health system, we can't get our doctors paid, our HIV program is falling apart, our hospitals are falling apart, our oncology services are falling apart. We are in a dreadful situation for everyone because of this PEPFAR crisis. And I feel bad for our government officials who are stuck with having to try and fix these things. Across the region, there is really, really a disaster happening now. And, we may get a PEPFAR light coming to save us, but honestly, I don't think South Africa is going to be the first in the queue, and I don't think we should be. I think Malawi should be, and Mozambique should be there. South Africa has the resources to fix this. And we probably should hope for the best, but we really should be preparing for the worst. But it doesn't seem like government seems to think there's a problem. We are going to have to max out on our creativity. And I think many of us are, like I said, we try and design studies, we try and get our collaborations going. There needs to be, but I also think there has come a time to us to start getting angry. And I think there is, and I would hope all of us are going to start supporting this, starting to demand accountability from the Department of Health around this, and maybe pull an Eskom on our healthcare system and start saying we need an expert group of people to get together to come and fix this thing in its entirety. That simply throwing more money at a broken system is not going to fix these things. And that at the moment, poor people are being failed left, right, and center. And that this problem with the HIV thing is actually only a symptom of a broader collapse within what is the public healthcare system. There's a lot that needs to be fixed within the private healthcare system as well, but nothing's going to get done with this current non-engagement from anybody within the system at all. And sorry, Jeremy, I think I went over time. I'll stop there. I definitely went close to over time.
No, you're good with time. Thank you. That's incredibly useful talk and really, really good to get such a good overview. As you said, quite depressing, but that's not your fault. That's the situation. Good to see at least some of the, how this interfaces with other aspects locally as well, and in the region, as you mentioned, with various role players. I'm just looking through some of the questions. Some of them have been sent to me in the chat, and that I'm glad that just to while I try and read some of them as well in the chat, that you mentioned this question of expertise, because I think that is the missing part as well. It's not just a question of money, as you rightly said. Money given to the current Department of Health is not likely to achieve anywhere near the results that we had with the engagement of these NGOs through PEPFAR, and it's really just a capacity issue as much as it's a funding issue, which definitely does exist in spades. Just looking down here, and some, so someone's mentioning about the difficulties of actually being volunteering, and I mean, yeah. Lucille is somewhat sarcastically saying NHI will be the big fix. I think that's been one of the challenges as well, is that the system is so sclerotic that I know I can talk from personal experience from the clinic at where I'm at Ellen Joseph, that even when people have volunteered, it's been very difficult to get them even approved by the Department of Health. We've just started some of them without approval, but that's difficult, it's almost in criminal indifference with this process. It's with things falling apart and the sort of denial that goes with it. One of the other comments was sent through, I see now in my direct message, is about this results for action campaign. I don't know if you're familiar with that, the RFA system that the NCD uses with viral loads and CD4s and CRAG results and things like that. And this person was saying that she thinks it's got big potential and underutilized. Do you think this could be a one of the ways that we try and plug the monitoring gap, especially with the people pulling out?
Absolutely. No, I think that the NHLS is like an amazing resource that I don't understand why we're not using it to monitor diabetes. Like, I don't understand why we're not using. But again, I get to the stage, the single patient identifier. Like, why can I walk into Clicks and give my ID number and they can give me like 14 different drugs that they told me I went to Western Cape to pick up my drugs 3 weeks ago and get my prescription. My single patient identifier is my ID number. Every time I walk into the Department of Health, like, I get 20,000 words as to why they can't implement it. It's like it's been public policy for 20 years and it hasn't been implemented. And every time I get told, there's like 17,000 reasons. And the NHLS could give us dashboards of you guys know, of every single disease process. We could be able to monitor how each one of these diseases is happening across the country. But all we get is more and more excuses. And, we have one SOE that functions pretty well in this country, and that is the NHLS. There are real fundamental problems there, but we could be monitoring so much of what happens in this country using the NHLS, but they won't implement the single patient identifier. So yeah, all these things are just so frustrating. There does come a time when I'm just tired of all the excuses. The minister is responsible for this mess, and he actually does need to be told to fix this. They have the resources. They need to get on with it. And I think one of the things I was kind of struck by the Adrian Gore presentation is there are lots of smart people here. They all know what to do. When I spoke to the SAMA president, he was saying, we have repeatedly tried to give input on NHI. He just doesn't listen. They don't acknowledge our letters. They don't acknowledge our input. Discovery have said we've repeatedly tried to speak to them. They just don't listen. And what it suggests to me is, like, we've got plenty of people here who know how to do databases. We've got the infrastructure, the pharmacies, the private pharmacies know how to coordinate databases. They know how to take my prescription and transfer it from one side of the country to the other. You can't do it from one side of the hospital to the other. It's that frustration for me is just is terrible.
And then, sorry, I'm just trying to read all the messages. But I think a good place maybe to end it is so you. What's really nice about this talk is you've given some potential solutions as well, which is really important, because otherwise we sort of wallow in pity more than anything else in it. But it is important to think about what the next steps could be and where to go. And you've done that really, really nicely. And then, a couple of the people in the chat have been asking, what could they personally do? So, I mean, is there anything in the next, let's say, short term, three months or less, that you think?
I think it's important to watch the political landscape. I think we're all invested in the health system getting better. And I think that we all want to be part of that solution. I think we all got good ideas and things. Like, I certainly don't have all the good ideas. The things I can contribute. I think it's important to this idea of a whole lot of experts supporting a group of people to take away this very destructive NHI thing, that if all we do is pour more money into a bad system, it's going to get better. I think we all know that that's not going to happen at this stage. We need the experts to get into the room to start examining what's wrong with the health system and start coming up with some things that are going to fix. We need them to do the ESCOM thing. I mean, it was remarkable what they did with ESCOM. Sure, it's not totally fixed. It's been very expensive, but we have health systems that are functional. And all of us, when I think about even the hospital system from 10 years ago in Gauteng, was functional. It wasn't great, but it was functional compared. And 20 years ago, it was very functional. These things are fixable. The infrastructure is there, but we need sensible people to go in and fix them. We can't continue to have a Gauteng Department of Health that just is absent. That's just stop governing. And we need a group of people to walk in there with authority to fix it and be held accountable to fix it. And I think we need to politically get behind. You want to know what you need to do in your personal capacity is get behind those political processes by saying, I'm supporting a group of people to come in and fix the system because I'm invested in staying and being part of that system. And I think that's what we need to say our voices are. Not that we anti the government or that we anti the minister or anything else, but we want the system fixed. He's had most of the last 17 years to fix it, and it's got worse rather than better. And Gauteng, I think, is a real testament to the fact that this approach hasn't worked. You know, is that we've borne the brunt of it. Actually, I would argue in the country.
Yeah,
no, I think what I can say is that within civil society, there seems to be, for the first time in a long time, like there's almost a tipping point. I think the HIV thing has been the tipping point where people have said, enough already. We've got, you know, the cancer people seem to be outraged, the NHI people seem to be outraged, the private sector is enough outraged, but this seems to have tipped everyone over the edge to points. I'm hoping something will come of it and we won't be disappointed just again.
Yeah, well, thank you. We're going to have to leave it there just for time, but lots of other good comments in the chat, which, sorry, I didn't get to everyone, but many people expressing very similar, you know, vibes and some suggestions as well. But thank you so much, Francois, again. I mean, your talks are always excellent. This was the best one I think you've ever given, which is really incredibly high bar because your talks are amazing usually. And really nice, I think, especially for us at the clinical coalface, to see some of the public health sort of zoomed out view and also the regional view, you know, to see what it's like for many other sub-Saharan African countries, especially because many people don't understand how different it is and how much worse affected they are really by this PEPFAR sudden stop. And again, as you rightly said, it's one thing to stop the funding, it's another thing to do it overnight, which just offers no ability to plug any of these gaps. So, you know, our thoughts are with a lot of these people dealing with even worse than us north of the border. But thank you again. Thank you very, very much for your time and we appreciate it.
Thanks, everybody. It's so lovely to see you all. Take care. Cheers.
Bye-bye.